Now let's look at hematological malignancies. The first one is acute myeloid leukemia, usually written as AML. AML is a clonal malignancy of myeloid bone marrow precursors. They are usually poorly differentiated and they accumulate within the bone marrow, and they also circulate in blood. Due to the absence of mature cells, including absence of granulocytes, patients are at higher risk for infections. In the presence of thrombocytopenia, which marks an advanced stage, patients can have bleeding tendencies. If the malignant cells are circulating in the blood, they can deposit in several organs, and rarely they can cause organ dysfunctions also. Now let's look at the etiology of AML. This accounts for up to 80% of acute leukemias in adults. For most of the patients, the etiology remains unknown. So as we age, there are certain mutations that accumulate and give certain proliferative advantage to particular cells, and this can lead to monoclonal proliferation, which if left unchecked, it can transform into leukemias. This concept is called clonal hematopoiesis. There are 3 documented environmental exposures that can contribute to leukemia, that is AML, and these include chronic benzene exposure, the second one being radiation exposure, and the third being prior treatment with alkylating agents and topoisomerase 2 inhibitors. Examples of topoisomerase 2 inhibitors include doxorubicin and etoposide. Other conditions that can evolve into acute myeloid leukemia include chronic myeloid leukemia, myelodysplasia, and myeloproliferative syndromes. There are a few genetic abnormalities that are linked to certain morphological variants of AML, and these include translocation of 1517, acute promyelocytic leukemia, inversion of 16 associated with eosinophilic leukemia in patients exposed to topoisomerase 2 inhibitors. A common genetic variation is seen at 11q23 chromosome. In patients exposed to radiation plus chemotherapy, chromosome 5 or 7 deletions are seen. In older patients with leukemia, with acute myeloid leukemia, a gene mutation called MDR1, that is multi-drug resistance efflux pump expression, can carry a worse prognosis. Let's now look at the classification of acute myeloid leukemia. The first type of classification is French, American, British, or also known as FAB classification in short. So in 1970s, a group of French, American, and British leukemia experts divided the acute myeloid leukemia into subtypes with naming from M0 to M7. These were based on the cell type from which the leukemia develops and how mature the cells are. This was based on the microscopic appearance as seen with normal staining. We have M0, which is undifferentiated acute myeloblastic leukemia. M1, that is minimally matured acute myeloblastic leukemia. M2, that is acute myeloblastic leukemia with maturation. M3, that is acute promyelocytic leukemia. It is also written as APL in short. M4, that is acute myelomonocytic leukemia. A subcategory of M4 called M4 EOS, that is acute myelomonocytic leukemia with eosinophilia. M5, that is acute monocytic leukemia. M6, that is acute erythroid leukemia, and an M7, that is acute megakaryoblast leukemia. Another important classification system for AML is WHO classification. This divides AML into various subgroups. The first among them is AML with genetic abnormalities. In that, there is AML with translocation between 8 and 21st chromosome, translocation between 16 and 16th chromosome, or inversion of 16th chromosome, acute promyelocytic leukemia with PML RARA fusion gene, acute myeloid leukemia with translocation between 9th and 11th chromosome, acute myeloid leukemia with translocation between 6th and 9th chromosome, acute myeloid leukemia with translocation between 3rd and 3rd chromosome itself, or inversion of 3rd chromosome, translocation of 1st and 22nd chromosome in megakaryoblast leukemia, acute myeloid leukemia with BCR-ABL1 fusion gene, acute myeloid leukemia with mutated NPM1 gene, AML with biallelic mutation of CEBPA gene, and mutation in RUNX1 gene. As this list is a constantly evolving list, there are a few provisional entries which are made, and as of 2024, BCR-ABL1 fusion gene and RUNX1 gene mutation, these two are provisional entries. The second subcategory is AML with myelodysplasia related changes. The third subcategory is AML related to previous chemotherapy or radiation therapy. The fourth subgroup under WHO classification is AML that is not otherwise specified. This classification is very similar to French American British classification. So now let's look at the list under this classification. AML with minimal differentiation, which is similar to M0 of FAB. AML without maturation, which is similar to M1 of FAB. AML with maturation, which is similar to M2 of FAB. Acute myelomonocytic leukemia, which is similar to M4. Acute monoblastic or monocytic leukemia, which is similar to M5. Pure erythroid leukemia, which is similar to M6. Acute megakaryoblast leukemia, which is similar to M7. Acute basophilic leukemia, and acute panmyelosis with fibrosis. Next subcategory is myeloid sarcoma. The sixth subgroup is myeloid proliferations related to Down's syndrome. And the seventh subgroup is undifferentiated and biphenotypic leukemias. They are also called as MPALs, that is mixed phenotypic acute leukemias. Let's look at the clinical features of acute myeloid leukemia. Most of the clinical features last less than 3 months before diagnosis. Common signs and symptoms include anemia leading to pallor, fatigue, weakness. There can be palpitations, breathlessness. The WBC count or white blood cell count may be low, or it may be normal, or it may be markedly high. We may see blast cells in the peripheral smear, but they may also not be there in the peripheral smear as well. If the blast cell count reaches more than 10,000 per microliter, then leukostasis can happen in brain and lungs. Minor pyogenic skin infections are quite common. With a low platelet count, that is thrombocytopenia, there is an increased risk of bleeding. And the common symptoms include epistaxis, petechiae, conjunctival hemorrhages, gingival bleeding, and all these symptoms are increased when the platelet count falls to less than 20,000 per microliter. Other features include weight loss, loss of appetite, and fever. When the neutrophil count reaches to less than 5,000 per microliter, there is an increased risk of bacterial and fungal infections. Some of the other clinical features include hepatosplenomegaly, which can be present in up to 1/3 of the patients with leukemia. Leukemic meningitis. This can present with features such as headache, nausea, seizures, papilledema, and cranial nerve palsies. Laboratory abnormalities of AML include hyponatremia, hypokalemia, increased serum lactate dehydrogenase or LDH levels, hyperuricemia, and even lactic acidosis can be seen. In patients with a very high blast count, there can be a spurious hyperkalemia, and a spurious hypoglycemia. This can happen because of lysis of blast cells and glucose uptake by blast cells in drawn sample. Now let's look at the treatment of acute myeloid leukemia. On presentation, the leukemic mass in the blood is usually in the range of 10 to the power of 11 to the 10 to the power of 12 cells. A diagnosis of complete remission is made when leukemic cell mass is less than 10 to the power of 9 cells and becomes undetectable in blood or bone marrow. So the typical treatment consists of two phases, that is remission induction and post-remission therapy. The duration of therapy usually lasts for 1 year. Now let's look at the treatment algorithm for AML. Once the AML is diagnosed, we have to classify the patient into previously untreated, that is a new patient without any previous exposure to medications, or a patient who has a refractory AML or has seen a relapse in the AML. Previously untreated or new patients are further divided into three categories: patients with favorable risk, patients with intermediate risk, and patients with high risk, or also called adverse risk. All these patients can be treated in two ways. For favorable risk, the induction therapy can be started with daunorubicin plus cytarabine based therapy. If complete remission is achieved, patient can be continued on IDAC therapy, that is intermediate dose cytarabine therapy. In patients with intermediate risk, an induction therapy consisting of daunorubicin plus cytarabine based therapy can be started, and if complete remission is achieved, the preferred choice of continuation of therapy is allogenic hematopoietic cell transplant, or if not available or if not tolerated, the IDAC can be used, that is intermediate dose cytarabine based therapy, or autologous hematopoietic cell transplantation can also be done if the patient's age is less than 60 years. In a patient with high or adverse risk, induction therapy can be started with the same daunorubicin plus cytarabine based therapy, and if the complete remission is achieved, patient can be subjected to allogenic hematopoietic cell transplantation. In all the three cases, if investigational therapy is present, the patient can be subjected to investigational therapy, and if that achieves a complete remission, investigational therapy can be continued. Now, in case if these patients fail to respond to therapy, so there is failure of remission, then these patients are subjected to the algorithm that is used to treat the refractory patients or patients with relapse. These are the patients where the patients can be treated with myeloablative hematopoietic cell transplantation, that is allogenic. In case where there is no suitable donor available, the options include investigational therapies, or patient can also be subjected to a autologous hematopoietic cell transplantation, especially in patients with favorable risk who have had an initial complete remission lasting for more than 12 months. Supportive care in treatment of AML includes packed red cell and platelet transfusions from cytomegalovirus seronegative donors. Colony stimulating factors are generally not recommended as they do not provide much benefits. They can be used in relatively older patients with any active infections. In case of febrile neutropenia, patients should be treated with broad spectrum antibiotics such as ceftazidime, 1 gram given 8th hourly, and if the febrile neutropenia lasts more than 7 days, a broad spectrum antifungal should also be started. So the induction therapy of AML includes daunorubicin in the dosing of 45 milligram per meter square of body surface area, or idarubicin in the dosing of 12 to 13 milligram per meter square of body surface area, which is given for 3 days, and cytarabine in the dose of 100 to 200 milligram per meter square per day, given as a continuous infusion for a period of 7 days. With this treatment, about 60 to 80% of the patients do achieve a complete remission. And if etoposide is added, it can increase the duration of complete remission. As a general rule, around 50% of the population achieve complete remission with just first cycle of therapy, and an additional 25% achieve a complete remission after second or third cycle of the induction therapy. About 10 to 30% of the patients do achieve a 5-year disease-free survival or even cure. And patients with translocation of 8 and 21st chromosome or inversion of 16th chromosome receive an additional cytarabine therapy for 3 to 4 more cycles. And patients who are at high risk for relapse can be considered for allogenic bone marrow transplantation. In patients with relapse, prognosis is generally poor. Bone marrow transplantation from identical twin or HLA identical sibling is a very effective treatment for acute myeloid leukemia. So the typical protocol uses a high dose chemotherapy followed by a full body irradiation. This ablates the host cell, all host cells within the marrow. This is followed by infusion of cells from donor's marrow. The complications from this procedure includes graft versus host disease, risk of interstitial pneumonitis, a possible risk of opportunistic infections, especially of cytomegalovirus. Studies comparing cytarabine therapy and bone marrow transplant for post-remission treatment are inconclusive. There are many new therapies which are in trials, and these include epigenetic modulators such as histone deacetylase, methyl transferase of DNA, chemotherapy agents including nucleosides, BCL2 inhibitors, immunotherapies, such as CAR T cells, that is chimeric antigen T cells, antibodies, and immune checkpoint inhibitor therapies are being trialed. Another form of therapy is targeting kinase in cellular pathways, and these include FLT3, KIT, Aurora, and Polo-like kinases. The next topic is chronic myeloid leukemia, or CML in short. CML is a clonal malignancy which is usually characterized by splenomegaly and increased granulocyte count. The course is usually initially indolent. When it reaches the blast crisis, or also known as leukemic phase, it has a poorer prognosis than compared to acute myeloid leukemia. So the overall survival is usually around 4 years. Let's look at the etiology of CML. Around 90% of the patients have a reciprocal translocation between 9 and 22nd chromosome, creating a chromosome known as Philadelphia chromosome. This produces a fusion gene called BCR-ABL, where the BCR part is derived from 9th chromosome and ABL part is derived from 22nd chromosome. The BCR-ABL mutation is seen in almost all bone marrow cells except T cells. This chimeric or fusion gene produces a protein that is 210 kilodalton in case of chronic phase and 190 kilodalton in case of acute blast transformation. Clinical features of chronic myeloid leukemia include gradually developing symptoms, easy fatigability, malaise, anorexia, abdominal discomfort, early satiety, usually due to the splenomegaly. Patients can have excessive sweating. In labs, patient can be expected to have elevated leukocyte count, which are usually found incidentally. The WBC count is usually more than 25,000 per microliter of blood, and granulocytes are increased, but band and mature forms predominate. There can be a basophilia accounting to approximately 10 to 15% of leukocytes. Platelet count can be normal or it can be increased. Anemia is a common feature of chronic myeloid leukemia. Neutrophil alkaline phosphatase score is low in contrast to leukemoid reaction, where the alkaline phosphatase score is elevated. Patient can have an increased marrow blast cell count, and patient can also have vitamin B12 binding protein and LDH can be elevated. The chronic phase usually lasts for 2 to 4 years. This can be followed by development of accelerated phase, where there is anemia, thrombocytopenia. There can be additional cytogenetic abnormalities blast cell count or blast count can increase in this stage, and usually over the next 6 to 8 months blast crisis develops, where the mature cells are far less when compared to blast cells within the peripheral smears, and the clinical picture usually resembles acute myeloid leukemia rather than a chronic myeloid leukemia itself. When the blast crisis occurs, the survival is almost less than 4 months. In the blast crisis itself, almost half of the cases become acute myeloid leukemia. 1/3 can transform into acute lymphoid leukemia. A small percentage of 10% can become erythroleukemia, and the remaining are undifferentiated. Now let's look at the treatment for chronic myeloid leukemia. In chronic phase, allogenic bone marrow transplant has the potential to cure the disease. Usually the preferred initial therapy is imatinib, which is a tyrosine kinase inhibitor and specifically inhibits the tyrosine kinase that is created by the BCR-ABL fusion gene. Imatinib is given in the dosing of 400 mg per day, and it causes a complete remission in more than 90% of the patients and cytogenic remission in 76% of the patients. If a matched donor is available, then bone marrow transplantation is the best option. Studies have shown that several CMLs are resistant to imatinib. Failure rates are higher with imatinib monotherapy. So in patients who do not respond to imatinib itself, other alternatives include tyrosine kinase inhibitors such as dasatinib, which is given in the dosing of 100 mg once daily, or nilotinib, which is given in the dosing of 400 mg twice daily in patients with T3-151 mutation. Resistance to all three tyrosine kinase inhibitors is seen. In such patients, ponatinib in the dosing of 45 mg per day is given. There are some response criteria that are used in chronic myeloid leukemia. Let's look at these. In hematologic, the complete response and incomplete response are seen. Complete response is characterized by a WBC count of less than 10,000 per microliter with a normal morphology. Other counts such as red blood cell count and platelet count should be normal. Incomplete hematologic response is seen when WBC count remains more than 10,000 per microliter even after therapy. In cytogenetic response, there is complete response, partial response, minor response, and no response. This is based on the detection of metaphase translocation of 9 to 22nd chromosome seen during bone marrow examination. In complete remission, of course, there should be 0% detection. A partial remission is when less than 35% is seen. A minor remission is when 36 to 85% translocation is seen. There is no remission when it is more than 86 to 100% of the cells. Another remission is molecular remission, and we have complete molecular remission and an incomplete molecular remission based on the detection of BCR-ABL gene transcript by RT-PCR method. And in complete remission, there should be 0 or less than 0.1%. In incomplete remission, anything more than 0.1%, it is called incomplete molecular remission. Supportive therapy include allopurinol at the dosing of 300 milligram per day, prevents urate nephropathy. In patients in blast crisis, imatinib can be used, but the response rate is not sufficient. Let's now look at myelodysplastic syndromes, or MDS in short. So these are clonal abnormalities of marrow cells. They are characterized by varying degrees of cytopenias, which can affect one or more cell lines. So myelodysplastic syndromes happen mainly in people who are more than 50 years old with a median age of 68 years. Similar to acute myeloid leukemia, exposure to benzene, radiation, and chemotherapeutic agents can cause myelodysplastic syndromes. There can be chromosomal abnormalities that are seen in up to 80% of the patients. So the most common chromosomes and abnormalities involved include deletion of 5th chromosome, 7th chromosome, 9th chromosome, 20th and 21st chromosomes are also involved, but these are less common compared to the previous ones. Some factors, if present, are associated with good prognosis. One of them is mutations in genes involved in splicing of RNA. This gene is SF3B1 gene. Certain genes that are linked to acute myeloid leukemia, such as RUNX1 gene and ASXL1 gene, confer a poorer prognosis to the patient. So the clinical features of myelodysplastic syndrome. Now let's look at the features of myelodysplastic syndrome. 85% of the patients with MDS have anemia. Around 50% of the patients have neutropenia. Around 33%, that is 1/3 of the patients, have thrombocytopenia. Bone marrow examination will reveal varying degrees of cytologic atypia. These include delayed nuclear maturation, abnormal cytoplasmic maturation, accumulation of ringed sideroblasts. These are iron-laden mitochondria surrounding the nucleus. There can be unilobed or bilobed megakaryocytes. There can be increased myeloblasts. Prognosis is usually defined by marrow percentages of blast cells, the karyotype, and the lineages that are affected. Now let's look at the WHO classification of MDS. 2022 guidelines of WHO classification uses myelodysplastic neoplasia in place of MDS, or myelodysplastic syndrome. So this is broadly divided into two categories. The first one is MDS with defining genetic abnormalities, and the second one is MDS that is morphologically defined. The first one in MDS with defining genetic abnormalities is MDS with low blast count with 5q deletion. It is written as MDS 5q in short. This has a bone marrow blast of less than 5% and peripheral smear blast of less than 2%. The second one is MDS with low blast with SF3B1 mutation, also written as MDS SF3B1. Even in this case, the bone marrow blast count is less than 5% and peripheral smear has a blast count less than 2%. The next is MDS with biallelic TP53 inactivation, in short written as MDS BITP53. Here the bone marrow blast count and peripheral blood or peripheral smear blast count is less than 20%. In MDS with morphological definition, the first one is MDS with low blasts. Here the peripheral blood will have a blast count less than 2% and bone marrow has a blast count of less than 5%. This is written as MDS LB. Next subtype is hypoplastic MDS or MDS H. Even here the peripheral blood has a blast count less than 2% and a bone marrow has a blast count of less than 5%. The third is MDS with increased blast, written as MDS IB. In this there is MDS IB1, MDS IB2 and MDS with fibrosis. MDS has a 2 to 4% blast in bone marrow and peripheral smear or peripheral blood. MDS IB2 has less than 5% in bone marrow and a blast percentage of less than 2% in peripheral blood. MDS fibrosis has a 5 to 19% in bone marrow and 2 to 19% in peripheral blood. Now, important points to note about certain subtypes is MDS IB2. In these patients, there can be OR rods also. In patients with hypoplastic MDS, the bone marrow cellularity is less than 25% and it is age adjusted. And in patients with SF3B1 mutation, presence of ring sideroblasts of more than or equal to 15% itself can be diagnostic of the disease, and there is no requirement of the mutation itself to be seen. Now, before we look at the treatment, let's look at a prognostic scoring system for myelodysplastic syndrome. This score takes into account various variables including cytogenetics, bone marrow blast in percentages, hemoglobin of the patient, platelet cells, absolute neutrophil count, and adds all of these parameters to give prognostic scoring. It's important to understand the prognostic scoring. There is risk, there is the score, there is median survival, and chances of AML transformation in 25% of the patients. So risk is categorized as very low, low, intermediate, high, and very high. A score of less than 1.5 is considered very low, and the median survival of such patients is 8.8 years. The amount of time required to convert 25% of the patient into acute myeloid leukemia is more than 14.5 years. A patient with a score of more than 1.5 to 3 is considered as low, and these patients have median survival of 5.3 years, with 25% of these patients becoming leukemic in 10.8 years. Intermediate is when the score is more than 3 to 4.5. Here the median survival reduces to 3 years, and a 25% conversion to leukemia rate is 3.2 years. A high risk is considered when the score is 4.5 to 6 with a median survival of 1.6 years and a conversion of 25% of AML to 1.4 years. A very high score is when the score is more than 6. This has a median survival of 0.8 years with a 25% conversion to leukemia in 0.7 years. This scoring is known as Revised International prognostic scoring system, or IPSSR in short. Okay, so now that we have understood the prognostic scoring system, let's look at the treatment for myelodysplastic syndrome. The first and foremost point is allogenic bone marrow transplantation is the cure, and it may cure 60% of the patients who are treated with bone marrow transplantation. As we have seen, the median age for myelodysplastic syndrome is 68 years, and most of these patients are too old to receive bone marrow transplantation, and these patients can be treated with 5 azacitidine in the dosing of 75 milligram per meter square of body surface area daily for 7 days every 4 weeks once. This can delay transformation to acute myeloid leukemia by 8 to 10 months. The other options include decitabine in the dosing of 15 milligrams per meter square of body surface area, which is given as continuous infusion 8th hourly for 3 days and repeated every 6 weeks. This can delay the AML conversion by 1 year, but in only 20% of the patients. A third option is lenalidomide. This is given in the dosing of 10 milligram per day, which is a thalidomide analog. This has lesser CNS side effects, and it causes substantial of the patients, especially with 5q deletion, to become transfusion independent. Patients with anemia and reduced erythropoietin levels can be treated with erythropoietin, and neutropenia can be treated with granulocyte colony stimulating factor. Now that we have understood myelodysplastic syndrome, let's look at myeloproliferative syndromes. There are 3 important myeloproliferative syndromes. The first one is polycythemia vera. The second one is idiopathic myelofibrosis, and third one is essential thrombocytosis. So all these are clonal disorders of hematopoietic stem cells, and another common feature is all of these are associated with mutations of JAK2 kinase, a point mutation with substitution of phenylalanine for valine at 617th position, and hence it is called V617F JAK2. This results in activation of the kinase. This mutation is seen in approximately 90% of the patients with polycythemia vera and approximately 45% of the patients with myelofibrosis and essential thrombocytosis. The first subtopic of myeloproliferative syndromes is polycythemia vera. This is the most common myeloproliferative syndrome. It is characterized by an increased RBC mass. There can be massive splenomegaly. The clinical features are due to increased blood viscosity. This includes neurologic symptoms such as vertigo, headache, tinnitus, and sometimes visual disturbances. There can be thrombosis and leading to myocardial infarction, strokes, peripheral vascular disease, and mesenteric or hepatic ischemia as well. Polycythemia vera has to be differentiated from other causes of polycythemia. The other causes are called secondary polycythemia. This is initially done by measuring the serum erythropoietin levels, and primary polycythemia or polycythemia vera usually has low levels of erythropoietin. These patients are further subjected to JAK2 V617F mutation analysis, as it is seen in approximately 90% of these patients. Polycythemia vera is managed by phlebotomy to keep a target hematocrit of 45% or less in males and 43% or less in females. Aspirin is given daily to prevent thrombosis. Some patients may require splenectomy to control the symptoms. Patients with severe itching can be subjected to Soralens plus UV therapy. 20% of these patients end up developing myelofibrosis, and approximately less than 5% of the patients can end up developing acute myeloid leukemia. In trials, a new drug called ruxolitinib, which inhibits the JAK1 and JAK2, is being tried. The second myeloproliferative syndrome is idiopathic myelofibrosis. This is a rarer disease which is characterized by bone marrow fibrosis, myeloid metaplasia with extramedullary hematopoiesis, splenomegaly also. Examination of the peripheral smear reveals dacrocytes or teardrop shaped RBCs. There can be nucleated RBCs and sometimes early granulocytic forms, including promyelocytes, can be seen. There are many diseases that can cause myelofibrosis and extramedullary hematopoiesis. So it is important to rule out these diseases before calling it idiopathic myelofibrosis. So these other causes or differentials include chronic myeloid leukemia, polycythemia vera, Hodgkin's disease, cancer metastasis to bone marrow. These cancers, especially from prostate and breast, certain infections, especially granulomatous infections, and even hairy cell leukemia. Treatment is usually supportive. There are novel inhibitors of JAK2 and telomerase that have shown reduced incidence of splenomegaly and marrow fibrosis also. One important thing to note is that wherever the patient is not having JAK2 mutations, they can have a CALR mutation leading to a mutant calreticulin. The third myeloproliferative disorder is essential thrombocytosis. This is usually incidentally detected, and there are many conditions that increase the platelet counts leading to thrombocytosis. And even in this condition, it is important to rule out other causes or secondary thrombocytosis. As a general rule, the platelet count should be more than 5 lakh per microliter, and causes including chronic myeloid leukemia, iron deficiency, splenectomy, malignancy, infection, hemorrhage, polycythemia vera, myelodysplasia, recovery from vitamin B12 deficiency should be ruled out. In general, these patients are asymptomatic, but they should be treated if they develop transient ischemic attack or migraine headaches, bleeding, or thrombotic disorders. Treatment: interferon alpha, anagrelide, or hydroxyurea. The symptoms do not occur until the platelet count reaches more than 15 lakhs per microliter. Bleeding can happen due to platelet absorption of von Willebrand factor. As with idiopathic myelofibrosis, these patients can have JAK2 mutations or CALR or calreticulin mutations. They can also have MPL mutations. JAK2 and calreticulin mutations account for up to 80% of the patients, whereas MPL mutation is seen in around 10% of the patients with essential thrombocytosis.